So hemifacial spasm is a hyper-excited or overly excited facial nerve. So your facial nerve comes out of your brainstem and it goes to muscles of your face. That nerve normally just moves your face when you want it to. When there's an artery pushing on the nerve right where it comes out of the brainstem, it can pulsate on that nerve, it can make that nerve overly excited, and then it makes the nerve fire when it shouldn't, which results in spasm on one side of your face. My name is Anthony D'Ambrosio. I'm one of the brain surgeons at the Neurosurgeons of New Jersey, and I specialize in microvascular decompression, hemifacial spasm surgery. I chose to focus on hemifacial spasm and microvascular decompression surgery because I feel that the more focused a surgeon is on performing what he or she does best, the better the outcomes are for their patients. I also know that this procedure can cure what is otherwise a very debilitating quality of life problem. And some of the aspects of the surgery require the surgeon to be subspecialized and focused. So all of those things together is why I felt performing microvascular decompression surgery is sort of one of the only things I do is critical. When you approach a nerve like the facial nerve for hemifacial spasm or the trigeminal nerve for trigeminal neuralgia, those are called cranial nerves. They are located in very deep, dark, small, narrow corridors of the base of the skull. To get to them without damaging something or pulling on something or hurting a blood vessel that you need to understand all of the anatomy of the base of the skull. You need to understand how to get to certain places in three-dimensional space that a traditional neurosurgery residency often doesn't cover. So being skull-base fellowship trained makes approaching the facial nerve actually quite straightforward. When you actually go in as a surgeon and you're able to treat the cause, which is the mechanical pulsations, you can imagine if that's the cause, you're treating it. And the effect of that can be immediate. You can see the nerve calm down right away. And when performed correctly by the right surgical team, the results have been published. It's just shown that the nerve just needed some space, needed some buffering to calm down, and the results can be amazing for patients. I love artificial intelligence. I love technology when it's appropriate. But when you're dealing with a patient and complex neuroanatomy, as well as whether or not the surgery is going to work, the judgment of an expert, a human expert, is just critical. There is no algorithm, there is no agent or bot that has the kind of information that an expert surgeon has in his or her head to know, you put the patient's story and their desires up against the MRI scan, up against what you're going to see in the operating room before you even select the patient or recommend surgery. That judgment is something that only an expert surgeon can bring to the table for the patient. The MRI scan combined with a high-resolution CAT scan gives me a lot of information that I cannot get from a report. I have to review the scans because oftentimes there are subtleties to finding the vessel, finding where it contacts the nerve, understanding exactly what I'm going to see. You have to spend time scrolling layer by layer, millimeter by millimeter through everything to make sure you know exactly what you're going to see before you get in there. And only the surgeon, the primary surgeon, can do that. Selecting a patient for an MVD for hemifacial spasm is complex. There's a lot of variables, but it's pretty straightforward in the sense that if they clearly have hemifacial spasm, it's inhibiting their quality of life, which often means they can't drive or there's some social anxiety. Oftentimes patients will go for Botox injections, which is a great first-line therapy. If they haven't gone for that, they should be told about it. They should try it. If they have gone for that and it hasn't worked for them and they meet all the other criteria, and you have a high-resolution MRI scan that shows that there is a vessel that's a candidate to be moved and buffered, those patients often are the perfect candidate. So I go through that whole process with the patient to make sure that we pick the right people for an MVD. You don't want to sign anybody up for an operation that you just know up front is like a coin toss. It's still brain surgery. It's brain surgery around some pretty critical structures. So you want to make sure as a surgeon that you're selecting someone that stands greater than a 90% chance of having a very positive outcome. There's a general anesthesia case. It is a small skin incision, so there's really no blood loss, but there's all these things like infection and bleeding that we have to say go along with the procedure. It's not non-invasive. So I try to put myself in the position of a patient or the loved one of a patient, and I say, look, are the risks really worth the benefits, right? Is there a very good chance that I'm going to come out of the surgery feeling a lot better and looking a lot better and just psychologically being a lot better than before I went in? And if I can't really say, with greater than 90% accuracy that's likely, then I try to dissuade patients from the procedure. From the moment the patient comes in the room, I like to be there to watch the entire setup. So I know where all the IV lines are. I know where all the neurophysiologic monitoring leads are. If the patient's not positioned correctly, by reducing the number of things that could potentially throw off the case in any way, shape, or form, you become a master, and your patients have masterful, wonderful outcomes, right? So to me, that's my job. My job is to bring a level of mastery and variable reduction so that my MVDs are as good as they possibly can be every time. Only about 10% of hemifacial spasm patients actually even hear about microvascular decompression surgery. That's been published. Educate yourself about it. It's never emergent, but the longer one goes without treatment and the longer one goes with significant compression on their facial nerve, the harder sometimes it is for that nerve to recover, even if the surgery's done well. So find the right people. There's lots of very good neurosurgical practices all around the world that do this extremely well. Find them, talk to them. There's no reason not to gather the information. If after hearing it, you still think surgery is not for you, that's perfectly reasonable thing. I just wouldn't be afraid of getting the information.